We're gonna go over this one patient monitoring chapter. It should be fairly quick. Then we will start the IV lab. Then next class, we will do next week, the 25th. We will do our exam first and our patient assessment in the field, or our patient assessment in the field, then our exam. Finish with that, and then that Friday we'll do the skills lab. Good? That way we're ahead of it on course, if that makes sense. I'm gonna do a blood test. That's important. I assume all of your services can do 12 lead acquisition, correct? I hope, yes, cool. Pulse oximetry, yes. Capnography. CO oximetry. Methaglobin monitoring. Who in here has life pack 15s? Who in here has something else? What do you have? Gross. Yours can do it. 15s have the ability as long as you have the rainbow cables on both ends. So you'll have that gray cable on the monitor side, and you'll have the white and red cable on the patient side. If the monitor itself can read, it's up to the cable to decipher it. So if you have those cables, you are monitoring CO and the methaglobin and all of that as well. Obviously, all of you are required to be able to take blood glucose. Basic blood chemistries is nobody in here that does chemistries besides us. Okay. Ultrasound.
We have ultrasound, but they're not on the.
No.
Only our bars. Don't ask no, just the.
I stopped in.
I'm gonna go with what is never for 500, Alex.
We used it once to try to get a pulse confirmation, but the battery died.
Well, it's kind of hard to keep the battery away when it's not plugged in. Anyway, moving on. Anatomy and electrophysiology. Your heart, mechanical pump that runs on electricity. You have cardiac muscle that contracts in a very uniform way. And they must receive constant supply of oxygen and nutrients and get rid of carbon dioxide waste products. We do that through which two systems? How do we get rid of CO? Respiratory and typically renal or metabolic. Here's your heart. We know that your heart has special cells that are what? Starts with an A.
What you said.
Automatistic. Allows cardiac muscles to function as a unit. You have your SA node, which is where? Where does that lie? Right atrium, towards the upper part of the right atrium, and that is the pacemaker of the heart that should initialize the initial electrical impulse to conduct a heartbeat. There's your SA node on a cartoon. Your AV node right there at the septum. You have right bundle branches, bundle ideas, all of that stuff. As you can see, these are the different pathways from your SA node. Fire over here to the left atrium, as well as to get to this AV node in this bundle. It has three pathways in case there is an issue. That's what I was trying to explain up there, is that your heart has safety mechanisms in place in case something fails along the way. Now, this is obviously the main internodal pathway here, right? What happens if something interrupts here and we have to go this way or this way? What do we think we're going to see?
Might take a little bit longer.
An elevated P wave.
Not elevated.
Absolutely.
So we're still gonna have a P wave because it's originating from here, right? So what is this? Who said what?
PR.
Prolonged PR interval, because we have a P wave, right? The QRS right here. This time is going to lengthen between this P wave and this QRS because it's taking longer to get there. And that's when we'll start. And once we get into cardiology, we'll go over it. But anything over one big box or 0.2 is considered a first degree heart block. And that is what that is in reference to, is there is a interruption in the electrical pathway of the SA to AB node that is prolonging that PR interval. Bundle of His delivers an impulse rapidly to the apex of the heart, which is where? At the bottom. Blood from the right ventricle to the lungs, left ventricle to the body, we know. ECGs record all of the electrical activity in the heart. Electrodes, the adhesive pads that have conductivity gel. That's why I told you, like, day one, don't preload your freaking electrodes. While it might be more convenient, yeah, you might be more convenient. That way you have to do less in front of the patients. The longer they stay out, the worse they get. You're like, why can't I see my EKG? Because you're jelly dry, bro. So it is better not to preload those. That's why they're in an aluminum bag, and most of them are in aluminum bags. Some of them are in paper with aluminum lining on the inside to protect the permeability of that bag so they don't dry out. So make sure you either reseal your bag or fold them over so air stays on them. Oh yeah, you have colored wires. In case you don't know which one goes where, white on right, snow over grass, smoke over fire, that whole thing, whatever cool little story you want to follow, just to remember. Your bipolar leads, one positive electrode, one negative electrode. When we're normally using a 3 or 4 lead, whatever you want to call it, 3 leads are all you need. You can do, even if you have 4, you can do it with just 3. But you create Ethenhoven's triangle. That's with leads 1, 2, and 3 site placements. That's where you can get heart rate, regularity, time to conduct impulse through the heart. You can identify if there's a pacemaker, or you can look if there's any abnormalities by the simple underlying rhythm. Now, is a 4-lead diagnostic? No. The only thing you can do is get a baseline set of information off a 4-lead. Rate, regularity, underlying rhythm. That is what you get off a 4-lead. Now, once you do this long enough, they've experienced it, you can look at a 4-lead and go, because it's not going to necessarily show the FT elevation in your bipolar leads. Usually those are in your augmented or peripheral reads typically. But even if they are, you can't diagnose anything. But you can get a good idea of what's happening electrically to do a 12-lead. Now, I'm under the thing that if I'm doing a 4-lead, I take the extra minute and do a 12-lead if I'm already there. Obviously, I have some inkling that I'm putting them on a 4-lead in the first place. Just take the extra minute and do a 12-lead as well. There's your augmented or your bipolar leads. You got right arm, and left leg. You can do without the right ground. That just helps during our 12 leads snapshot, and that's why they put them on there. That is Ethenhoven's triangle. So we have our P wave, which is what? Correct, atrial depolarization. Your QRS. Ventricular depolarization along with what? And do we typically see our atrial repolarization? Okay. We have our T wave, which is what? And what is a U wave? Anybody know?
They're positive, they follow the two-way, electrolyte abnormalities.
Typically, if we're looking for hypokalemia, early stages of hypo, you'll see what it is. It's this right here. That little extra bump after the T wave is usually indicative of an electrolyte imbalance. You'll have an upward deflection that's like a small T wave that you can. And it doesn't necessarily have to be hypokalemia, it can be hypocalcemia. That's just showing that there's an electrical or electrolyte abnormality causing a delay or secondary repolarization. So you have ECG time intervals. Your PR interval would be from the beginning of our P wave to the beginning of our R wave. And you have an ST segment, which is from where? Anybody know? Which part of the T? What part of the S?
The end of the S and beginning of the D.
Starting from the first most upward deflection of the S wave, so when it starts coming up this way, right, to the end of the T wave. Some books will tell you from to the beginning of the T wave because that denotes where you're going to be. We here do both. We look at where the ST segment starts. So is it above, below, or at the isometric line? So that is important of knowing Q to S or S to T. Where does that T wave start? And it's also important knowing how long from the end of the beginning of the S wave or the upward deflection of the S wave to the end of the T wave of how long is it taking to repolarize, because that's what it is ventricular repolarization, right? So we need to know how long that time is. So those are both important. Your ST segment, your book is probably referring to is the time from the S to the beginning of the T starts, but it is also important to know when it ends. Cardiac rhythm, we should know all of that. Limitations. Cardiac monitors cannot tell whether your heart is pumping effectively or efficiently. Pretty much what the actual mechanical ejection fraction is, there is no way of knowing that. And as we know, we've put dead people on the monitor before, right? And they still show stuff on the monitor. It has no way to know if it's beating at all. The only thing your cardiac monitor is going to tell you is if or if there is not electrical activity. That is all. Mechanical and electrical do not always match. That was why I said before, it is important for when you look at your monitor to feel some type of pulse to make sure that with every beat on the monitor, you're feeling a beat at your fingertips. And if you're not, you have a mechanical to electrical abnormality. Something is wrong. And then you need to feel, palpate, whatever, what their actual heart rate is. Because if I'm getting every other or every third beat, a monitor showing 90, their mechanical heart rate's only 30. That's the problem. Lead ECG is a pre-hospital standard of care. Should be done on most patients. Again, cardiac is respiratory and respiratory is cardiac here. So we do 12 leads on all of, or should be doing 12 leads on all of those patients, along with syncope, altered mental, any of those things. It all starts at the heart and lungs. Artifact is all that deflection and noise that you get in your EKG. That means you can't read shit because there's so many up and downs that you don't know what's what. Rather annoying. I will say it is very important that you get your initial 12 lead, if possible, while not moving, whether it's in the truck or in the house or wherever. It is best to do a stationary 12 lead so you have a good fundamental base. You can still get acute points off of those. Things that can cause that artifact, obviously muscle tremors, patient movement, loose electrodes is a big thing, certain radio frequency interference, machine malfunction, bladder or spinal stimulators, cell phones, any of those things can cause interference. Also, you having the wires look like you made a balloon animal out of them cause a lot of interference within themselves. So it is important, instead of just throwing the bundle of shit right on their chest and telling them to breathe still, make sure the wires are fanned out accordingly and they're not all crossing over each other. Make sure we take the time to make a loop in the cord so it's not a big pile, and make sure we don't have it on their belly where they're breathing, so each time they breathe during the 12 lead, it's causing those wires to rub. That's going to get a bunch of artifact all through all of that. Indications to do ECG monitoring: chest pain, irregular pulses, suspected MI, high heart rate or low heart rate, or any patients receiving advanced life support measures. And I agree with that fully. If you're going to do any type of it, like true medication administration, you need to be doing a 4-lead and a 12-lead. Now, do you need to do a 12-lead after every medication administration? No, but you need to get a baseline, and then if you see some type of change on your 4-lead, you rerun your 12-lead. Something as simple as Zofran can cause huge cardiac issues. Zofran is known to prolong your QT interval. And if you do that enough, you have a problem, especially if you push it too quick. That's a very simple medication that even advanced can get. They don't have monitored though. Good job, State. But that is something that I feel like you need. Any type of medication you give that's invasive, you need to do at least one to get it underway. And if you, again, do it initially, and then if you give something and you notice that QT is prolonging on your monitor on a 4-lead, that should be continuously monitoring, run another 12 and see if there's a change. If you don't know, first thing you need to do is turn on your monitor. That's helpful. Clean the skin. Try not to stick it in big clumps of hair, whether it be body hair or head hair that's hanging down. Electrodes on the chest wall instead of the extremity, that is a varying degree. We put ours, I teach to put ours out here on the shoulders or on the arms, not on the bone. I don't like trunk EKGs because it's a more condensed picture, and I'll go on the inside of the calf muscles. But at the same time, if you're in a pinch or whatever and you do a trunk, make sure that it's limb to limb or trunk to trunk. So if you're going to go lower body on the belly, you need to go lower body on the, or upper body on the chest wall. Don't go upper body on the shoulders, on the outside shoulders here, and then on the trunk. Pick one or the other. It's limb to limb or trunk to trunk. Old Philips MRX, those things were beasts. Wish they still had those things. At least try to wipe down your patient with some type of washcloth or towel or something. That's a bit much, but if you got the time, feel free. Apply the electrodes. Again, see how there's not a big bundle of crap sitting on his belly giving artifact every time we do that. Print out a rhythm strip on there. This is good to know. This is on a page in your book. 183, to know where your positive and negative electrodes are for your sight picture. And it gives a good idea of the view of the heart. So left arm to right arm is lead 1 is going to be showing mainly what? The atrial view, right? It's going across the top. My left leg, right arm, is going to show what? My entire heart. That's why lead 2 is our primary lead, because it's going from my left leg to my right arm, and it's getting the full encompassment of the full electrical activity of the heart. Then we have our left leg to left arm, which is showing what? The ventricle part of the heart. Now, you're going to pick up all electricity from all views of the heart, but it's just the spread in which it's given. It's still going to pick up the QRS, which is ventricular depolarization. It's just where is that sight picture coming across from? That's why lead 2 is your primary lead. Every monitor that is produced in the United States defaults to lead 2 for that reason. ACS, acute coronary syndrome, myocardium fails to receive oxygen due to a coronary blockage. That muscle becomes ischemic, suffers injury, and will eventually die if not corrected. Ischemia is a deprivation of oxygen. Injury is damage from prolonged ischemia that will result in death, if not corrected. Infarction is complete death of that tissue. Goal of us is to not necessarily correct the MI, but stop the infarction process, meaning at least let's spread the death of that tissue, whether it's through vascular dilation with the administration of nitro or morphine, or reduces the oxygen demand on the heart through morphine, if you believe in that, or to give heparin to help break down that clot, or give Plavix to help fight the coagulation aspects of blood. Whatever your protocols are, our goal is to stop that infarct process. Best thing we can do, acquire a 12 lead, give aspirin, nitro, morphine, oxygen, and from there, that is the minimum standard, or those four things right there. Aspirin, nitro, in most cases. Again, I will teach you what I believe, but you're free to do what you choose to do. You're free to listen to what you want to listen. Follow your protocol. I'm not saying I'm any more right than that douchebag that's bald on Facebook, not the buff guy, the other guy that's got weird teeth. But you follow who you want to follow. You believe what you want to believe. I will teach you what I believe. And if you believe something different, please feel free. I'm not going to dock you for your treatment process. I'm just going to teach what I'm going to teach. Rhythm strip is one continuous look from the heart from single direction. 12 lead shows from 12 different directions. Now, how many wires are on a 12 lead? 10. That's because we're using different grounds as negatives, like we're reproducing lead grounds on some of those. Your unipolar leads are your AVR, your AVL, and your AVF. On your augmented leads, when you disconnect that ground, I don't know anybody that does augmented EKG. Does any of you guys do augmented EKG in the field? Those 6 peripheral leads give a 360-degree circle. I feel like that's a little wide. It's more like a 270, but it's supposed to give a 360-degree view. Just because you'll learn once we get to cardiology. Will you get rid of my band theory back there for a second? I'll use that board here in a second to show you. So your peripheral or pericordial leads are those 6 extra leads that attach to your 4 lead. All 12 leads record the exact same electrical activity. So what is seen in lead 1 is also seen at V6, which are the same moment in time. It's not this is here, then this, then this. It is the same 3 seconds produced in all of those leads. Now, going back to a 360-degree view, this is why I say that it's wrong. So, oh, that was a windy throw. Did not mean to hit you. You throw that in the trash. Thanks. You didn't make it either. Doesn't matter. All right. Now, I assume most of your 12 leads look like this, correct? This is how it's broken up. So, there's something I'm going to teach you that is an easy way to remember what part of the heart all of these represent. Now, does anybody know what it is?
Big line, little line.
So you got big Y, so this would be L, I. Little I would be L, I. And that's backwards. and then all. Now, what is a letter that you don't see up here? Anybody know where you can have an MI? Anybody know what that stands for? Posterior. Now, what all these stand for, anybody tell me what the L stands for? I?
Inferior.
S? A?
Anterior.
Now, what this is saying is if I have elevation in these two leads, what does that mean? I'm having an inferior MI. If I have elevation in these two leads, I'm having a lateral MI. If I'm having an elevation in these two leads, I'm having an anterior septal MI. This is telling me the location of where the MI is at. But what we don't see is the posterior. So that's why I don't agree that it is a 360-degree view. Now, you ask how, and we're kind of getting a little ahead of ourselves, but since we're here, how do we tell that there is a posterior MI? What indication do I have? Anybody know?
I can't remember, but I just know you move V forward to the right side.
That's to confirm it.
Yeah.
But anybody know what we would look like before we do a reverse or a posterior 12 lead?
Isn't it like a winding against the keyboard?
Bullshit. You only use it in like this would be one of them. Widespread depression with or without AVR elevation. Now, a good precursor, widespread depression, elevation here. I'm not even going to do a reverse. I'm going to start treating right now. That is a posterior MI. But if I have widespread depression and this is still depressed or looks normal, I'm still going to do a reverse because it's a high likelihood, high probability that I'm having a posterior MI.
Are those the rarest?
Posterior? No. Something going on with AVR is super rare.
What would be the rarest then?
I don't know that there is.
So there isn't one that's more common than the other?
Inferior and your septal, I would say your most common, just because that is the area that is affected by the three big supplies of the heart. Your circumflex, your right and left anterior descending. Like those are your biggest vessels. Those are the most that do the work, and that is the part of the heart that is most dependent on blood supply from those big three channels. So it is very common to see them there. And just while we're here, or when we get there, we'll see how many of you remember. H standing for high and L standing for low. High lateral and low lateral. So, when we're dealing with this, when we're looking at that, what I'm seeing in lead one, top left lateral there, is the same time frame that I see in V3. It's just what is happening from this picture and this picture. You have 12 cameras taking a picture at the same time and then putting it all together. So it's not a different run of each thing. So I know some of you are going to ask them, why do I see different things in this lead and I'm not seeing them here? Because that part of the heart is where it was picking up ectopy or having an electrical interference. And it's not going to be demonstrated in those parts of the heart. So you'll have some stuff that if I have PACs, like through my 12 lead, I might see them here, but I'm not going to see them here because of the location on the heart, because of that view that I'm going to be getting from those cameras.
It's elevation in 2 and reciprocal change in 2.
We'll get into the reciprocal changes thing later on because there's a whole algorithm for that. You can still have semis without reciprocal changes as long as certain criteria is met. If you have left bundles, you're not going to have reciprocal. It's a wider probability you're not going to have reciprocal with bundle branches, but you have to have concordant or decoordinate elevation or depression in certain leads to meet Scarbosa's criteria, which is how you denote left bundles. Right bundles have to be demonstrated off a troponin. Like it's a whole different thing, and we'll go over that cardiology. But yes, the term reciprocal changes is important. But, huh?
I said, you can literally see your brain working faster than your mouth.
Yeah. So we'll get into that in a different day. Do what?
Pump brakes. It's super pump brakes. Slow down, downshift.
So there's the placement. Now, most of us do 12 leads wrong just with placement. We just kind of guess. Very rarely do I see my divider or my provider sit up here and feel where those intercostal those spaces are. We're supposed to go to that third or fourth preferred intercostal space. Some teach second, some teach third. As long as it's relatively close, we can't have V1 and 2 up here at the bottom of the neck. We're going to get a bad view. Now, people's anatomy, particularly women, make those things sometimes difficult because their shirt used to say nice shirt, now it says nice shoes. So sometimes that can be a little wrong, but
You've seen it.
you know.
You'd be real nice. Just hey, hold that right there.
But it's no secret that the female anatomy is more difficult to work around than the male. There's typically more stuff there. But the one thing that you fight with men is hairy chests, and sometimes you can't feel anatomy because typically we're of larger stature. So you have to kind of feel around. Typically we have broader chest or barrel chest that it's harder to get landmarks. So while this might seem like a very mundane thing, lead placement is huge. Especially once we start getting into cardiology, we start looking at access deviation and things like those. We start looking at access deviation and C elevation. We better confirm that our lead placement's correct before we start pumping them full of heparin, things like that. What we can show is injury, ischemia, or necrotic changes. We'll look at, from a 12 lead, you can denote whether it is, it is more probable that it is a new injury versus an old injury, just by the morphology of certain waves. If I've got a downward deflected P wave in a certain lead, that's usually indicative of an old artifact. If it's upward, then it's indicative that it's new onset. That's just something that happens and we can denote from a 12 lead. That is a good chart that's on page. That kind of breaks this down into a little bit more scientific here. Again, right side of the heart in a vertical plane is AVR. Very typically are we going to see a whole lot of stuff. There are a few cases, which we will go over, but it's very rare. Your ST segment and your isometric line is what we're going to determine that ST elevation, that myocardial infarction, or those reciprocal changes of depression in those leads. We're going to base it off that isometric line. And what the isometric line is that line that our P wave starts on. Like this here, there's an imaginary isometric line. Just like if you ever look at your 12 leads from your service provider, there's usually a really faint line or little dashes or something that says, here's where my ship is. And even if you don't, you should see, all right, all my other stuff is here, right? But my T segment starts upward deflection here. That's way above the isometric line. Angioplasty, which is the actual surgery that takes place, is what can correct that. And then obviously we have medications on the truck that we can either treat or stop the progression of that issue. Again, the heart's electrical activity determines nothing off the mechanical pump. Postural changes can cause issues with our 12 leads. It is only a 3-second run, so we're seeing what's in that 3 seconds. That's why concurrent 12 leads can be important, especially if you're noticing a pattern with certain timing, or hey, we're throwing PVCs every third thing. Let's try to time this, or whatever the case might be. Timing is huge. Does not directly examine the right ventricle, unfortunately. And the biggest thing is mistakes interpretation. I can take a 12 lead to 5 different cardiologists and get 6 different denotations of what they are. And the problem is, there's likely that 4 of those things mean the same thing. They're just phrased or worded differently. That is the biggest thing to understand. That you might say one thing and somebody else saying the other, and they just mean the same thing or just using different words. There can be early recognition and treatment for that ACS. We can denote early ST segment elevation or a new bundle branch. Now, the patient's going to need to know what their history is to do that, or you're going to have to EKG to reference. You're not going to know whether it's new or not. There's no way to know that they've had this for 2 minutes or 2 years. But most of those people who see a cardiologist regularly know, hey, do you have something called a bundle branch block, or a left bundle branch block, or a right bundle branch block? You're like, I don't know what those words mean. Probably a good indication that it's new. You can look for depression or inversion of that T wave. Again, depression is going to show certain ischemia, as well as the inversion can show old ischemia or old infarct in that area. Reasons to do it: chest pain or anginal equivalents. I firmly believe anybody with any type of chest pain should get one, just for whether it's rule out, because again, everybody presents differently. So even if they're complaining of that pain right here and they have a history of GERD and acid reflux, it's a good idea to just go ahead and take the 2 minutes to do a 12 lead, just so you don't miss something and be like, we just gave them fluids, and you roll into the hospital with a STEMI. Save yourself from looking like an idiot and take the 2 minutes. Acute ischemic stroke. Why is that important? They're having a stroke. Why do I need to do a 12 lead? Exactly. Where did the clot come from? And there could be more. Did the clot in the brain break off and make it back its way to the heart? All of that stuff is important. Pre and post cardioversion, that's big. I just hit you with 200 joules. How's that heart doing now? Good idea to take a Gandy. That's for the stable patients. You want one before and after. You're unstable, you're just going to kind of get it after, because if they're unstable, it's going to be real stable here in a minute if you don't address it in the form of asystole. So just go ahead and address the issue, and we'll get one when we can. And again, suspected electrolyte imbalances or disturbances. We can see, based on the morphology of those waves, are we having a calcium issue, a potassium issue, a magnesium issue? Do we have endocarditis? Do we suspect endocarditis? We can do all of that off the morphology of the waves. Should do them on overdoses, blunt chest trauma, because obviously with blunt chest trauma, that might be a, holy shit. Okay. If you're going to damage the muscle, that can cause an electrical disturbance because the muscle is damaged. Any type of arrhythmia, respiratory failure, and ventricular failure. Again, breathing is heart, heart is breathing. Do them on both. Because what if they are having trouble breathing, right? What can be a cause of having trouble breathing? Metabolic issue, what else? Left-sided heart failure? Right-sided heart failure? Combination there of both? Maybe the blood's not pumping to the lungs correctly, or it's not pumping, the right side's not pumping enough into the left ventricle, so we're starting to drown in our own blood. All of those things we can denote off of the 12. I'm not going to go over how to do it. We should all know how to do it. Just make sure we get rid of any excess hair. They can stick through some hair. You look like a woolly mammoth. You're going to need to shave that. And no, we don't use pads to fucking shave their chest. This is not a hibachi waxing. You have razors in your truck that are required by state for a reason. Yeah, we used to have one douche here that would take electrodes, big sons of bitches for pads. Yeah. Not only did you just waste $38 of my shit, that is rude.
You look really required that state. Interesting.
I got about 1,000 of them. I need some. But yeah, that's why razors are required on your truck so you can shave the chest hair. Now, typically, providers like myself, we buy the nice single blade ones that probably pull hair more than they cut it, but it's better than a full scale waxing with electrodes. There's your placement. So, and we're going to go over placement today if we have enough time. If not, we'll do it next class. The way that I put ours on, or what I put mine on, I go V1, V2, then I go V4, V6, then I hit V3 and then V5. That's how I do mine. Just because I get my main landmarks of 1 and 2. I know 4 goes directly right by the nipple, 6 goes directly mid-axillary over here, and then I know I'm going to meet halfway with V5, and I'm going to meet halfway at an angle with V3, and I've got my spread already done. That's just how I do it, because everybody is shaped different. Like, my chest circumference is different than hers. She's significantly smaller than me. So if I just start putting them on, I might have them too far apart and then be on the back with my V6. Or like me, you might put them close together and V6 ends just left of my nipple. You're not going to get a good sight picture, so that's why I place those first. This should be at a little bit more of a curvature, in my opinion, but it's not far off. And the problem is, you see here, here's V1 and 2 right here. Look where those axillary leads are at. They're so close. What you're doing is you're condensing that sight picture. So you're not going to get a widespread picture of anything. Everything is, we always take a picture like, hey, how you doing? No, we want a little bit further view so we can see what's going on. That's my belief. That's what I'm going to teach. You do you. When you get if you've ever looked at an EKG, if you've ever looked at an EKG, you get your STJs and STJIs over here of what that level above that ST segment is. They'll give you numbers that are negative or positive inflection. There is a 12 lead in my mailbox. Will you go get it? She is trying to figure out what's going on. I can tell you from here that it's LVH for sure. So that's fine. Procedure, have the patient lay supine. While it is best to do it while they are laying flat because we don't have them all hunched over, if they're having a respiratory issue or something, do not compromise their status to have them lay flat. But if you have the ability to lay them flat or a 10-degree angle, do that and just say, hey, just for a moment while I do this, I'm going to lay you down. That lets everything relax and nothing's going away. But again, if it's a respiratory patient, don't be like, I'm going to smother you for 20 seconds. So good luck. Don't do that. Transmit to the receiving facility if you have that ability. Here we here we typically send one if we believe it's an MI to our local hospital where med control is at, as well as the receiving facility of where we're going, because we don't transport MIs here typically. So we'll send one here just so the doctor can have a case review for our run. And then, or if we have questions about it, we can like, just got you a 12 lead, whatever the case might be. Is that it?
Question?
Huh? Yeah. So I'm going to pass this around. This is why placement is important. you look at the time difference, I got called to assist on an MI back in May, 9:30 at night, because it was an advanced crew that was getting an alert on the truck for the elevation. And you'll notice 2 minutes later, they no longer had ST elevation. That wasn't because I'm a fucking wizard and fixed it in 2 minutes. It's because the placement was incorrect.
What was wrong with the placement?
They were too close together and they were too high up. The electrodes were, I think 2 of them were actually touching. A and P. Hemoglobin, iron carrying protein that transports oxygen, containing red blood cells. Oxyhemoglobin is when oxygen is bound to hemoglobin. Deoxygenated hemoglobin is when it's not. Obviously, we know the more red blood cells we have, the more oxygen we can carry, right? The problem is, why is SpO2 monitoring not great? Two reasons in my mind.
Because there's a pretty large delay.
There's at least a 2-minute delay, number one.
Then I'd say number 2 is it only reads up to 100, so you got all that extra free radical oxygen get thrown in there.
It doesn't differentiate oxygen from carbon dioxide.
That. All it knows is that it's occupied. It doesn't know what it's occupied by. So this is just saying 98% of your blood is occupied by something. Now, if you have the ability to do methyl or CO monitoring, it'll tell you, hey, we're having a bunch of CO. So if I see a SpO2 of 100 and then my CO alerts at 25, I know I've got a big issue and that my SpO2 is probably not O2. It's probably just O, along with some carbon, right? So that allows me to do that. But again, it's at least a 2-minute delay on that reading, and it can't differentiate. It just knows that it's occupied.
It also doesn't read very well.
Yeah, fingernails, rough nails, calluses, people that have arthritis or contractures in their hands, like, you know, the finger probe's 2 inches long and then, you know, they make 19 bends in their finger by the time it just doesn't sit right. Small fingers, cold fingers, there's just so many elements that can be conspired in this. Lower the pH, the more readily hemoglobin will be released or will release that oxygen. Again, so you can kind of discern, as long as you rule out all the other things, whether they're acidic or alkaline through with their SpO2 reading, but it's really not a good indicator. You see this term PCO2 and PO2. You may know what that is. Partial pressure. How much is in that artery or that vein? As you'll see here, PCO2 is directly related to pH, which isn't hyper important unless you're doing labs. Elevation and body temperature can cause a shift to the right, or also known as an oxyhemoglobin dissociation curve, which means that you have more availability or less availability of oxygen than you do red blood cells. A fall in body temperature will bind that oxygen more tightly. I could next time throw that in, I'll do that. Pulse oximetry is non-invasive. Again, it's just measuring the saturation of hemoglobin. We would like to think that it is only oxygen, but it can be a number of things. And we have those like squishy ones that you kind of squish the side and stick your finger in. Those are dog water. Then you have the ones that clamp on that if you can get their, you know, as long as they don't have hood rat nails or anything, you can get their finger seated in there correctly. But again, if they have any type of fingernail, it doesn't get seated in there. And then you have the stick-on ones that we usually use for pediatrics, but you know, you have to use on some adults just because of certain things. But then those cost $20 a piece and all of that stuff. So there's different ways to do it. A lot of the flight crews, Zoll is known for having a really good ear one. You usually see that with the flight crews. You can do a toe on kids. They have some lip ones, they have some nose ones, and you have those forehead probes. There's just different kinds of measuring that you can use. That's a portable one. That is a rainbow cable. Problem with pulse oximetry, requires pulsating artery blood flow to obtain an accurate reading. So if they have low blood pressure, you're going to get an accurate one. Anything that inhibits perfusion will alter that reading. And this is the big thing. Oximetry is not a complete measure of respiratory or circulatory sufficiency. You can still have breathing problems with an SpO2 of 100. Again, all that's saying is all of this hemoglobin is bound to something. Doesn't mean that that's what's delivering or we're exchanging waste any better. You can click there to watch a video. Normal oxygen saturation is 96 to 100%. Reading below 95, suspect shock, hypoxia, or respiratory compromise. I think that's a stretch. I think it depends on what that patient's normal is. Patient has history of COPD, emphysema, smoker for 20 years, and their oxygen's 98. I'm going to be concerned. Like, for real. I'm going to be less concerned if their SpO2 is 90 or 92. I'm okay with a reading that's 90 or above. You get down into the 80s or 70s, you need to do some aggressive airway management as far as whether it be RSI or intubation, CPAP, BiPAP, something needs to be done because living in the 70s and the 80s are not good. Pulse oximetry, apparently they noted as the 5th vital sign. Okay, that's cool. I would put end title way before pulse oximetry. I'm not telling you how to connect one. CO2, how many people here do CO2 monitoring, whether it's nasally or through a tube? Okay. I feel like this is a more accurate representation on your breathers than SpO2. Now, I feel like they do work hand in hand. You can't make a decision one way or the other without the other. But it measures the amount of CO2 that's being expired. It can be sailed through the mouth or the nasal passage. Now, these people that are having trouble breathing, that are in that tripod position, prior to them being intubated, where are they breathing on? Huh?
No.
Their mouth. Right. They're sitting there trying to create their own teeth, and they're. So if we put an end-tidal nasal cannula on them, is it going to be super effective? What can we do? Put it by their mouth. Stick those hooks in their mouth. Let them breathe the oxygen in through there, and let them breathe it out. Now, is that going to be 100% accurate? No. Is it going to be better than going somewhere where they're not breathing from? Yes. It's something, right? The end-tidal CO2 is an evaluation of that cellular metabolism, your circulation, and how well you're ventilating. Drastic changes in pH can seriously alter your normal body functions, including your ability to blow off or retain end-tidal CO2. Or just CO2. Capnometry is a non-invasive measurement. That's what we use, a little baby plug-in. Then we have something called a colorimetric from the 70s. They used to use that during intubations to see if they were in the belly or not. It's the thing that goes from purple to yellow and yellow to purple. Heat. The problem is heat, air, anything like that can alter the color. So to me, they are super useless. The hospital over here still uses them as the red words. They will use that over waveform capnography, and I don't know why. That's just what they do. Waveform, electronic CO2 will not only give you a waveform, but as well as a numerical value. So that's your colorimetric. There's your waveform. Where's it out here? And then here is your numerical value. Continuous waveform reflects CO2 concentrations over time, and you can trends on those. In limitations, you can get false positives and false negatives. That is a possibility. In a numerical value, but the waveform will always be correct. So if you have some weird waveform readings, can you go off your numerical one? No, because it's probably not interpreting the waveform correctly. It's not going to interpret the number correctly. But if you have a unified waveform and it's continuous, it's a good possibility that your number is in fact correct. Cannot detect hyper or hypocarbia. That's literally what they do, but okay. If gastric contents or acidic drugs contact the paper, that's for those colorimetric ones. So that makes sense, yes. On the colorimetric, it can't tell you, it just says you there is the presence or there is not. If gastric contents or something hit that paper's dead. Utility decreases over time. If it gets wet, the color changes. If it gets dark, it's difficult to read. If it gets too hot, it starts fading that color. Now, the actual electronic one, that gives you a number, lets you know where they're at, lets you know what their waveform is. If they have a bronchospasms or they have an obstruction or whatever the case might be, depending on the shape of that waveform will tell you what's going on with that patient. You better use end title in every intubated patient. Whether you can do RSI or you do codes, you must, it should be a requirement that you use end title on all of those patients. Because while you're working a code, that can tell you if you've had ROS. Because are you going to get a discernible rhythm during CPR on your monitor for your EKG? No. You're going to be getting vitals. They're not going to be correct. Can you see a huge end tidal jump in the number from when they're breathing out of the tube or what's being released that there's now gas exchange occurring? 100%. My end tidal is 18 and it jumps to 70. I've probably got ROS. You can gauge the effectiveness of compressions and the ventilations based off of your waveform. You should also do it in a majority of your trauma and head injury patients as well. Because where is your breathing control center? In your noggin. And if you have multi-system trauma, you don't know whether there's a collapsed lung or all of this because that can happen over time. How many of you listen to breath sounds on every patient? You're a fucking liar. You lie, you sit on the throne of lies.
Yeah, don't need to
Oh, I can't let you run.
I got thrown to the wolf because I did it once.
Yeah, you learned, man.
Yeah, I learned.
Yeah, exactly. Okay, that makes difference. Yeah, you got your ass bit and now you're like, not again. That makes more sense. It can detect accidental extubation, tube obstructions, disconnection from the ventilation system. I believe like the large gust of air would tell you that you're also disconnected, but if you're deaf, I guess you can look at that reading. You can monitor respirations of sedated patients. You can notice bronchoconstriction or bronchospasms based off the waveform morphology. Carboxyhemoglobin, carbon monoxide is the number one cause of poisoning in industrial companies. Problem is, CO is odorless, tasteless, and colorless. So we could all be here right now, and I could be slowly poisoning you all, and no one would know it until the first like 3 of you pass out, which is happening on this side of the room. So it might be a CO leak over here. Is he on the toilet sleeping? Yep. Acute CO poisoning, short exposure to high levels. Chronic is long or recurrent exposures in short or long periods of time. There's your normal readings. So less than 15, anything less than, ours alarm at 10, so anything less than 10 is normal to have in your body just from cars and shit in the air. 15 to 20 is mild. You might start experiencing headache, dizziness, some nausea and vomiting. 20 to 40, we start getting pretty big symptoms. You'll have tachycardia, there'll be tachypnic, they can have chest pain, they can be confused or completely syncopal. Anything above 40, you're going to have some problems. You're going to have respiratory arrest, pulmonary edema, flash pulmonary edema can cause cardiac arrest. Long exposures to anything over 60% is going to be fatal. Again, those rainbow cables use 8 wavelengths to measure those things. So if you have that ability, you can measure all of that now if you have the correct cables. Now, granted, those cables are about $1,200 for the set, but they are more rugged, so long term it might help, but they're not cheap. You can use it to triage your patients, especially hazmat situations. You know, fuck is the word I'm looking for all the shit, the co-ops, stuff like that are a bunch of chemicals, industrial facilities that have a bunch of chemicals. You can kind of measure those things if they don't know what the exposure is. Connects the same way as SpO2 does most of the time. It's the same. That is a rainbow cable there that does all of them. Methemoglobin is hemoglobin that is oxidized and it cannot transport oxygen. When those levels rise, significant hypoxia can develop. Methane is not good for your lungs. Major causes is increases that production and then does not deoxifies the hemoglobin, so they cannot carry oxygen. Those are all things you can give. I see about 3 of those things that might be readily carried. 2, 3, yeah, 3, 4 that might be readily carried among services. Earliest and most severe symptoms, when you see the heart and brain affected, you see arrhythmias, you see confusion, loss of consciousness, things of those. Very similar to CO. There's your percentages in those. Total hemoglobin monitoring measures the amount of red blood cells and protein carried on them. Very early recognition for organ perfusion to avoid hypoxia. This is usually only done. You can do these through some of these multi-wavelengths, some of the specialized ones, and you can also do it through invasive pressure monitoring as well. Your luck. There is your normal readings. So this is something that we'll go over once we get into especially the perfusion index and your PDI to measure changes of your perfusion index during your respiratory cycle. We'll go over that during trauma as well as airway management. But there's the definition of both of those that you'll probably need to know. There's actually a formula you can use to measure the perfusion index and all of that. You remember yours from your class?
Sure don't.
That tracks.
Why do you think I'm sitting back here? I'm trying to relearn how to be a paramedic.
Islets of a Langerhans. So this is part. Why do you keep going the wrong way? For blood chemistry, obviously we're measuring your glucose levels, but it has to deal with the endocrine cells that are obviously found in the pancreas. You've got 3 different types of cells that it can measure depending on what monitor you have. Then your body also has alpha, beta, and delta cells. Your alpha produce glucagon, your beta produce insulin, and then your delta produce somatostatin. You do need to know those 3 different ones and what they produce. We should all know what the diabetes is. Insulin production. Whether it be too much or not enough. Typically, it's not enough. Normal blood glucose are 80 to 140. Now that again, relative to your patient, if your patient is diabetic, their normal might be 300, and that'd be their normal. So if our normal is 80 to 140 and we're at 60, are we going to see a huge change? There might be some confusion or just some sweatiness, right? But if their normal is 300 and they're at 60, is there going to be a big change? Yes. I can be at 60 and still be functioning and have a diabetic that's normally at 300 be at 80 and be out cold. So that number is going to be relative. That is for a non-diabetic patient. Hypoglycemia, we know, can cause severe brain damage from lack of glucose, which is required for energy and delivery of nutrients. Hyperglycemia can also be life-threatening dehydration because there's so much, you're pretty much a hypertonic solution, and it's just excreting fluid all the time. And obviously we should know the glucometer does. Now, you do need to calibrate your glucometers. Every time you're supposed to calibrate your glucometers, whether it be daily or weekly, but you definitely need to do it every time you change out a set of test strips, because each test strip is going to be different. Make sure that you clean it properly. I'm the type that if their hand isn't dirty, I will just wipe it one time and then wait a minute. That way it's not saturated in alcohol. I'll poke, waste one, squeeze again, and then measure it. That way all of that alcohol is still in the fingers, diluted by that first wipe of blood. Some people don't clean their finger the first time. Some people sit there and wipe it until it's crystal clean and they'll eat off of it. That, to me, dilutes the sample. So just your miles may vary. Hand sanitizers can cause a lot of feedback that's wrong. If you get a aberrant reading, go ahead and do it again. Indications, I do it on everybody. It should be done on everybody. It's quick, doesn't take long. While it's invasive, it's very much minimally non-invasive. Something that you can check, and you know, low or high glucose can mimic a lot of medical conditions out there, and it's one of those H's and T's you should rule out on damn near every patient. We should all know how to use it. Give it here. You sure did. Basic blood chemistries. Do any of you do blood draws for your hospitals or Leo departments or anything? If you do it, you should always do it right after peripheral access is gained before you flush the site. So you'll do your venipuncture as you normally would, but instead of flushing the site, and directly connect your hub to it, and you'll obviously use that specialized hub that you'll plug those vials into that'll vacuum puncture, pressurize it. There is a certain order that those need to be done in. It just depends on what color of the rainbow you guys carry.
Why does it matter? What?
Because there's certain preservatives in each vial that can influence the next testing. So if you do it out of order, you can take some preservatives out of the final test, induce it into the first test they're going to do, and it can chemolyze or coagulate the blood sample.
So if you do it out of order, it's
Correct.
close.
And you can usually tell by looking at it. If you ever had a vial that looks like super frothy on top, you've mixed, like, you'll have your vial and it's like blood, and then it starts like whitening and getting like kind of bubbly. That's where you've induced a certain preservative into the other preservative, and it's just hemolyzed that blood. I'm sure you've seen that then. As you can see here, these are anti-coags in it, and that's the order that they. Some of them are yellow. Like I said, these can change from company to company. Your red always goes first because there's nothing in there. And it's, if you don't have a vacutainer hub, you can use like a 10 cc to draw on, but you have to be sure that you don't do it too quick, because that will also hemolyze the blood and give invalid readings. And then if you do it that way, you need to make sure that you get enough to fill each vial, and you still have to fill the vials in order, because each time you puncture, unless you use a new needle every time, each time you puncture, you're taking that preservative from vial to vial. That is the vacutator, that specialized hub. Now, sometimes in lab, what you guys will experience is you're doing a straight needle vacutator where you're leaving a metal needle inside their arm and then just connecting to the hub. If you're doing blood draws, it won't be an IV style. That is also a thing. Those you have to be super careful not to manipulate because that is a sharp ass needle sticking in someone's arm. And the last thing you want to do is push down on it a bunch and just destroy the vasculature. All of those tubes have a line on them that is a minimum fill line. They're going to vary depending on the tube that is needed. Yeah. Make sure, again, you label. Here we label with our initials and the time. We should be labeling with our initials on the time on the tube. And then again, we put them in a little bio bag, the clear bio bags, that we should write the patient's name, date of birth, who drew it, and what time we drew it. Again, time is of the essence there. So if you drew it 45 minutes ago, all but one of those samples is dead.
What's our color order here? Yellow, blue, green, purple. Yellow, blue, green.
And if you ever have, like, again, that red can change, or that yellow can change to red. And that's the one that they've had that for a hot minute.
The red is the one they have to register these, and then they'll,
The red is the first one.
and then they'll do gray last, which is lactic, which you have to have on ice. So gray is lactic,
Gray is last.
which we don't get the lactics. Like you'll do that.
You'll do that in the ER in your time. So if you ever do a gray, that's a lactic and it has to go on ice. The ones that we have in the truck here are yellow. Right?
Or yellow, green, blue.
No, not the old ones. Yes, those colors.
I do, green goes on ice too.
Yellow, green, blue, green, purple. Yellow, blue, green, purple.
There you go.
They'll give you a little
Card.
clothespin thing with the colors on it. If you do it here.
It's just a little
It goes-
safety pin that's got 4 colored beads on it, or 5 colored beads on it, or something that shows you.
A lot of people still carry them on the back.
Again, you can use like a 20, you're gonna need more than 10 ml. You're gonna need about a 20 ml syringe or 2 pins. If you're gonna do a syringe, if you've pushed anything and you're like, oh shit, I need a blood draw, you need to waste at least 10 to 20 ml out of that line. So you need to draw back 10, you need to draw back another 5 to 10 as weight, because anything that you pushed, even if it's fluid, is gonna dilute that sample. So you have to get anything that is relatively close and in that line out. So you need to waste at least 10 to 15 ml, if not more. If you're gonna do 15, you might as well do 20, 2 10 cc syringes of waste before you do your blood sample.
When you do that, you don't have to like actually push the syringe down, right? It just set it down.
Say that again.
Like when you put the syringe.
Oh yeah, the vacuum, the tube is vacuumed, so when you put it in, you should just poke it in and the plunger will go down itself because those tubes are pressurized. Complications, obviously damage to the vein wall. You can have bad removal of the IV. You can have hemolyzation of that blood sample. Those are what they typically measure in the ER. Those are what the normal values are. I'm going to let you go over these cardiac biomarkers by yourself in your book. Again, we went over this earlier, your electrolytes, your positive charge or cations, and your negative charge or anions. These are all of your stuff in your body and stuff that we can typically give: sodium, potassium, calcium, magnesium chloride, bicarbonate, phosphate. I've never seen serum lactate given, but that's in your body. We have point of care testing, is which we do here with those iStats. We can do pretty much the CDC and the troponin here. And yeah, it's got blood gas on it as well. The Chem8s do. It does translate into better patient care because we can see things that we can't monitor, we normally wouldn't know. What is the difference between a non-STEMI and a STEMI? You can see one and not the other. Still cardiac death. One is showing electrically and one is not. And can you see a non-STEMI anywhere besides on a point of care or blood test? So those people that are like, oh, I've got severe chest pain, you put them on 12 lead and everything's normal, and they go to the hospital and then they go to the cath lab, that's because they were having a non-standing. Still having cellular death, still having cellular ischemia. You just couldn't see it on a monitor. 2 devices, iStats, which we carry, and your epochs. Those are the 2 big, there are other ones out there, but those are your 2 big brands of testing. You can do this bedside electrolyte, hemoglobin, hemocrit, troponin, lactates, and it helps us with our treatment methods here. That's what the iStats look like. Cartridge goes down here, little bottom. These are all, this is how you navigate it, and you have to put in your provider ID number and the patient's number, which we usually use the birthday here, and go through the on-screen prompts. Up here is where there is a RFID and battery. The RFID is what we hold up to the printer, and they'll actually print our lab values in the trucks for us just through wireless or Bluetooth or whatever technology it uses. And then again, the batteries are up top. Problem with, huh?
Can we see that? I'm not seeing
You'll
that.
grab one.
Grab cartridge too, or?
Actually, yeah, grab a cartridge out of the fridge and bring me one of them out of the supply room, please. Problem with the, huh?
This wrench? Get the whole thing, or?
Yeah, that's fine. Problem with these is they're super, super temperamental. They don't like the cold, they don't like the heat, they don't like bouncing around, they don't like you conducting traffic with it in your hand. So when you do these, well, I mean, I'm just saying that because you'll have providers in the back of the truck holding it and doing other shit. When you're doing all this, it can't calculate the blood sample. So when you do it, you set it on the thing and, you know, make sure you're not going over Moonwell Road with 19 speed bumps in it, because you're probably going to have a failed reading. But again, they are temperamental to heat. It'll say out of temperature range, and you have to sit up there and either hold it up to the AC for about 2 minutes to cool it down, or hold it up to the heat for about 2 minutes to warm it up. It's got about a 20-degree difference or 30-degree variance in temperature operation. It's from like 61 degrees to like, I think 85 degrees, and out of those 2 parameters, it says, nope, not gonna work. So that is a problem. Yeah, pre-hospital, you have to be compliant with CLIA regulations. It's a whole federal process. It's a bunch of bureaucratic red tape. So you can't just like go buy one and be like, we're gonna do this, because then you can't order the cartridges or anything. This should be good.
Eric's calling me, he's right in here.
Where are they at? That or you can't get in the state. Indications, again, potassium, sodium, hemoglobin, hemocrit, troponin, lactate. We've got 2 different cartridges here. We've got a troponin, which does only troponin, gives us 1 value. Downfall to that is it's 10 minutes. So if we see ST elevation, we'll still do a troponin just to have that number, but we start treating that. If we go through all of our H's and T's and rule out everything and there's no ST elevation, they're still having severe chest pain, we do the point of care and then we go. 8 to 10 minutes for that test to be done. 10-8s, which are our blood panels, those take 1 to 2 minutes, so those are fairly quick. You do that while you're doing the IV. By the time you secure the IV and you push your Zofran or hang your fluids and stuff, the thing's pretty much done. You do arterial blood gases, you can get partial pressures of oxygen and CO2, you can get bicarbonate, we get anion gaps and all kinds of stuff on ours. Here's your normal readings for lab values. You probably need to know them. What page is that on? 214. Which one was it? Couldn't find it or couldn't? So this is an iStat. It's a pretty large device. When we go over IVs here in a minute, whoever I start one on, we're going to draw your blood and we'll see what your values are at. But they're fairly easy to navigate. You turn it on. It's got like a DOS screen. And you can either do last cartridge, which was a cartridge error. That's handy. Hello. Or we can do a new cartridge. and then it'll tell us to input our operator ID, then put the patient's ID, and then insert the cartridge. They're fairly easy to use, but like I said, you have to have a bunch of bureaucratic red tape to have it. Ultrasound uses high frequency radio waves. To accurately do ultrasound, you have to go through training. No one just picks up ultrasound and knows what they're looking at. M waves, there's B waves, there's all different kind of waves that you need to be able to discern from. But it is nice for fast exams and trauma exams and looking for abnormalities, looking for pleural effusion, any type of that stuff can be seen on ultrasound if you know what you're looking for babies. If you want to do that, we've used that here quite a bit. We've had pregnant mothers in auto accidents. They're like, I just want to make sure my baby's okay. I'm like, we can do that for you. There's your baby. And that, I think it's benefited quite equally from that as it has fast exams, just from a patient comfort standpoint. But you've got those mothers freaking out because they just ate the steering wheel and they're concerned about their baby. We can say, not saying nothing's wrong, but as of right now, your baby's not happy and it's moving around. And that gives them some comfort.
Fetal heart tones too.
Fetal heart tones. You know, they think something's wrong. You can sit there, tell you what it is, what the rate is, all of that. We know how to do you'll know how to do the fast exams, your right upper quadrant, your left upper quadrant. You work in a circle. You can do suprapubic, look at the bladder and all the muscles in that area. You can do cardiac. Problem with cardiac is you got to get through the ribs, so you have to be real good with your angles and ultrasound to get through the ribs, because ultrasound does not travel through bone. So you just get one big dead area, so you'll be looking at part of the heart. And if we have time, if it won't be today, we'll do it next Friday. We'll go over the ultrasound stuff. I'm not going to train you in it, but I'll just show you how to use it. You can help use it on the truck, but obviously, unless you work here, you haven't gone through the training, so you don't know what you're reading, but we'll at least explain some things to you. Limitations, technology itself is nearly limitless. The problem is the big one, poor training and inadequate oversight. We have the ability to see a lot of things on here and you just have to know the anatomy very well and know what you're looking at. You got to know that I'm looking at either intestines or liver, or that is interstitial space or interstitial fluid or blood. You have to know what you're reading. The big one also is overreaching the scope of practice and protocols is, we use this as diagnostic, but not for treatment. Like, we need to go off of our index of suspension or our differential diagnosis. We shouldn't be going in blindly going, I don't know what's going on. I think that's a bleed TXA. We should have an idea that this was the mechanism, these are the blood pressures, these are their heart rates, they're rigid and tender, or whatever the case might be. We're going to use this as a confirmatory, non-diagnostic. But the problem is a lot of people don't do that. You can see all of these things plus more. Any questions on any of that? All right. So let's take 5 minutes, clear off your desk, do all of this stuff. We'll go we'll do the ISTAT stuff real quick, and then we'll do the IM, IV. I'll put it right. Huh?
I'll let you start that on a cap if you take that one.
Why your cap?
I don't know, it's a weird thought.
I don't know, I was kind of curious to see what my lab values were.
Your fucking caffeine is 1 gram. Who? You turn the lights on. Maybe she went with her friend. We're not kicking the door off.
No.
No, please.
When is it?
You don't do that.
Which happened?
We're both going right ahead.
Long?
Yeah, if you want to get your homework out that you're supposed to
Hit or
do.
miss, she's unresponsive. This last time they were there, she was an EDA, Shifter was reading high on our monitor, and she wouldn't go.
There. You can go get me 1 star kit and 1 IV of our.
You should, yeah,
And
start getting your neck,
Huh?
start getting your neck.
we don't have any left.
Yeah.
They put a box back.
There was, the other day, there was half a buck. I don't think,
Please bring your homework up to the front and just set them in this pile right here. Make sure your name is on them.
I got nowhere with the, Secretary of State and Kentucky stuff.